Hi, my name's Ariel, and I want to talk about chemotherapy. So I've been an oncology nurse for almost 10 years now, and I've administered medication at the bedside, and I've also worked in phone triage, and I have a lot of experience of chemotherapy and all the different regimens. So what is chemotherapy? It's medication that is administered to someone who has cancer. So chemotherapy kills actively dividing cells. Okay, so it's cytotoxic. So what it means is that it kills the cells. Okay, how is chemotherapy administered? So there's multiple different routes of administration for chemotherapy. The different routes of chemotherapy include oral, so actually taking a pill. Then, of course, the number one people think of is intravenously. So that is through a vein. So you can get it peripherally through a vein in your arm, or you can get it through a central line venous access, like a port, like myself. I do not have cancer. I have a port for other reasons to give myself IV infusions. So in regards to, you can get it intravenously through your arm. It depends on what the medication is. Some chemotherapies are considered a vesicant, which means that it is very, very toxic to the vein, okay? So therefore, most likely would need a port. For example, doxorubicin, the Red Devil. Okay, moving on. But you can also, if it's shorter treatments, you can get it peripherally. If not, you have to get it intravenously. There's other routes of administration, which include intrathecally. And what that means is they actually put the chemotherapy and do like a lumbar puncture and actually administer the chemotherapy into the patient's spinal cord, okay? For example, if anyone has any disease in their spinal cord. Also, another way that they can do it is intrathecally via a Meyer reservoir. That is when you have a port actually implanted into the top of your head where you could actually administer medication around into your cerebral spinal fluid. A lot of chemotherapies do not cross the blood-brain barrier. Therefore, in some cases, they actually need to put chemotherapy intrathecally right into the patient's Meyer reservoir, okay? So there's many different routes of medications for chemotherapy. So let's just review that. Oral, by mouth, intravenous, peripherally, or whether through it's a central line, intrathecally, which they place it into the patient's cerebral spinal fluid, or through an Meyer reservoir, okay? So what are the three pillars of cancer treatment? So the three pillars of cancer treatment are chemotherapy, radiation, and surgery. Each different type of cancer, like for example, breast cancer and colon cancer, treatment plans can be very different. Or for example, breast cancer and lung cancer, or pancreatic cancer, or so-and-so. The treatment plans differ depending on it. So first, one aspect, or the pillars of treatment, is surgery. Can we cut it out? Let's get it out of here. Can we get it out safely? And when you're probably hearing in shows, excuse me, you may hear in shows where it's like, do we have clean margins? Do we have clean margins? And what that means is in surgery, when they're trying to get the amount of tissue out, they're looking to see if there's any cancer cells around where the surgery is. So when they keep going and then they send it to pathology while the patient is still in surgery. Okay, the patient is still under surgery and they're trying to get as much of the tissue out until they get clear margins, okay? And the really important of getting clear margin is so it doesn't metastasize out, okay? So surgery, we're trying to cut it out, okay? And then another pillar is chemotherapy, okay? Can we give chemotherapy to shrink the cancer? If you get chemotherapy before having surgery, it's called neoadjuvant chemotherapy. Neo before, adjuvant chemotherapy, okay? So, for example, in breast cancer, if a breast cancer is very large and has a lot of blood vessels or a lot of, blood circulation to the cancer, what they may do is do treatment first to shrink the size of the cancer and then do treatment, then do surgery, okay? Then, therefore, they can cut it out as much as possible. And then finally, let's say one more thing. It's neoadjuvant, and then if it's after surgery, so for example, in lung cancer, they may do a lobectomy, take out where the lobe where the cancer is, okay? Have you recover, and then do chemotherapy. That is called adjuvant therapy. After surgery is called adjuvant therapy, okay? Neoadjuvant, so neoadjuvant is before surgery, adjuvant is after surgery, okay? So another thing, for example, is of neoadjuvant therapy is if someone had ovarian cancer, okay? And what they want to do is they want to shrink the size of the cancer by doing 3 cycles of treatment and then going to surgery to debulking to take out the cancer. At this point, when they take out the cancer, and then they do more chemotherapy. Okay. So now let's do the last palliative treatment for cancer is radiation, okay? Usually how radiation is, it's multiple days in a row, so usually 5 days in a row for an extended time period, usually for 30 treatments. So what does that mean? It's 5 weeks, 5 days a week, okay? There are patients who get concurrent treatment. What is concurrent treatment? That means that you're getting chemotherapy and radiation at the same time. There are times where it's called sensitized treatment, which is where you get the chemotherapy and then you get radiation right after. Why is that? Is because we're thinking the chemotherapy's in there working and then we're zapping it. We're zapping, okay? For example, for a patient who has cervical cancer. So that is like sensitized concurrent radiation, okay? Now, if we were doing a patient with, who's getting concurrent treatment, for example, another patient is like head and neck. Another type of treatment is lung cancer, okay? You get surgery and then you do treatment, and at the same time you're doing radiation. Okay, what are the main side effects of radiation? Are fatigue. Patients feel so wiped after. So what I tell my patients is, when your body's telling you to rest. Listen, your body's telling you something. Listen, okay? It's the number one problem undergoing radiation. Another thing that's really bothersome is irritation or skin irritation from radiation. Okay, you can get like a burning, a burn. What I always like to tell patients is, if it's on the front, make sure you check the back, okay? Because what you're thinking, radiation is not just going right to that spot. It really is going right through you, targeted to where the cancer was. So if, for example, if you're having breast cancer and you're going through radiation and you get burns on the front of your chest, I would definitely, check your back to make sure that there's no burning behind you. Patients do ask if they're going on adjuvant treatment, so after surgery, why they're going on chemotherapy, and they're like, well, we got everything, or we think that we got everything, is because there can be microscopic cells left over that, of course, the surgeons cannot see. We do not have x-ray vision. Even though there's clear margins, there can be small cells left behind. So there are times, that's why they might want to do radiation right to that area to make sure that they get all those cells. Another reason what they could be doing is doing chemotherapy after surgery. So that's called adjuvant therapy. So after surgery, adjuvant therapy, okay? Why does someone get chemotherapy? Is because chemotherapy is a systemic treatment. So if there are some little lung cancer cells that are trying to move away after surgery, you're going to kill them by receiving the chemotherapy systemically, okay? Everyone says it's so poison. Yes. Technically, it is. It's poison to the cancer cells, but it does kill some healthy cells. And when it kills the bad cells, it does kill the good cells. So what cells do it kills is rapidly dividing cells. What are those rapidly dividing cells? Fingernails, skin, hair, eyelashes. So that is why a patient may lose their hair during treatment, is because those are rapidly dividing cells and the chemotherapy is killing those cells. In regards to having the scalp cooling, I do know that is not foolproof. I do know that it is not the end-all be-all, but it is an option if a patient is going to forego treatment. If you're going to forego treatment, it's worth it to do the scalp treatment. Personally, would I do it? Probably not. But I would just educating that this is an option for others because some may forego treatment. Okay. Now back to chemotherapy. So patients may ask, why do I get chemotherapy every 3 weeks or every 2 weeks or once a week? Or who decides that regimen? Who decides that? So, and some patients may say, oh, well, I go every week. And some patients may say, I go every 3 weeks. Chemotherapy regimens depend on the primary cancer. Lung cancer treatments are different than breast cancer treatments. They may have the same chemotherapy drugs that overlap, for example, carboplatin and Taxol. Patients may ask, why are my treatments every week and someone else's treatments is every 3 weeks? And why is it every other week? Or patients may wonder why it differs. It does differ depending on the type of cancer. So if you have lung cancer treatment, it may be 5 days in a row to go to the cancer center to get multiple treatments, compared to breast cancer treatment, it's every 2 weeks. And also in breast cancer treatment, one patient can be every 2 weeks as the other patient can be every 3 weeks, and it all differs. And the reason why the regimens are a certain number or a certain days apart is because of the chemotherapy is targeted to kill those rapidly dividing cells when their cell cycle is about to regenerate, okay? So when it's regenerating, that is what's leading, that's why you have to stay on track of when you're going to be taking your medication. Staying on track with the chemotherapy. For example, you don't want to keep extending it out because you want to make sure you're killing those cells exactly on how the research shows. also one thing is that if you ever wonder, well, why did my doctor choose this? And why did my doctor decide this? They always go by NCC guidelines, which is the National Comprehensive Cancer Network, which is giving all the guidelines in regard to what regimen you will be receiving. There are chemotherapy drugs that overlap, very much so. For example, carboplatin and Taxol is the same treatment that we might be given for breast cancer, but it might also be given for ovarian cancer, okay? Or endometrial cancer, any of the women's downstairs cancer, which may be a different regimen than the other.